Hi everyone, it's René again from JJ&J, and we're up with our fourth video for the year in the JJ&J academic program, and we're going to be talking about hemodynamic monitoring. Okay, so today we're going to cover three main topics. That's going to be arterial pressure monitoring, central venous pressure monitoring, and saturation. What is hemodynamic monitoring exactly? So hemo means blood. Dynamic means movement. So obviously it's the movement of blood through the body. So we monitor certain of these factors, and it's about monitoring the cardiovascular system, and that's why we're focusing on arterial pressures, central venous, and saturation with that pulsatile pulse. Respiration and ECG don't really make up part of hemodynamic monitoring, although we do still monitor those two, and they're definitely part of our vital signs. So I will touch on them a bit later. Okay, so let's start with the arterial line. And what are the indications for an arterial line? Frequent arterial blood sampling to save the patient a lot of arterial stabs, of course. Continuous monitoring that is needed beat to beat in cases like major surgery or patients requiring inotropic support. Of course, there's many other examples, but just to give you an idea. There's definitely advantages and disadvantages to arterial line monitoring or arterial blood pressures versus the traditional blood pressure cuff. And some of them are, for advantages, we have a real-time display and it's continuous beat to beat, like we mentioned. Also, at very low blood pressures, the arterial line will be far more accurate than a blood pressure. I'm sure you've seen it before where it pumps up and continuously pumps up and struggling to measure those low blood pressures, and often will just come up with question marks on the monitor. So for a very unstable patient, obviously the arterial line is preferable. But there are some big disadvantages too, and that is that there's skill technique required. There's potential complications, and they are quite severe, and that it's definitely more expensive. If you have a look at that horrible picture there of arterial occlusion giving that necrotic looking finger, I'm sure unfortunately we've all seen that in the ICU. We can also have hemorrhage. Remember, if it bleeds from this insertion site, it's an arterial site, and you can bleed from an arterial bleed to death if it's not monitored. We can cause emboli, thrombus and air, accidental drug administration, which is diabolical, of course, for limb perfusion, sepsis, although it's not classified as a CLABSI, it's still almost relatively the same, in that arterial lines have actually been proven to sometimes cause worse CLABSIs than a central line. So infection control is very important. Arterial vasospasm, and then like we mentioned, the arterial occlusion, which can be temporary or sometimes permanent. Okay, so some parts that we need for an arterial line: we need arterial catheter, we need the set, we need a pressure bag, a transducer, and cable. And I just wanted to quickly mention how important that pressure bag is. What is its actual function? It's to keep the line patent. We pump it up to 300 millimeters of mercury, and that ensures the delivery of 3 mils per minute. It prevents backflow of blood, which, if we have a backflow, might cause a thrombus. It prevents air embolism, and it maintains accurate readings. Okay guys, let's have a look at the arterial waveform in more detail. So this first upstroke is all about systole. So when the ventricles contract, we're going to have a systolic upstroke. It's going to culminate in a peak, and we call that very top of the wave the SBP, systolic blood pressure, and it's the peak, and that's going to be the 120 or whatever your patient's is, the highest part of your blood pressure. As it starts to come down, we have systolic decline, and you'll see another little positive wave there, and that is the dichotic notch, and that represents aortic valve closing, or the end of the ventricles contracting. And then our ventricles relax and we have diastole. So after our dichotic notch, that last part of the slope downwards, we call the diastolic runoff, and it ends in the minimum diastolic pressure, which will then be the 70, for example, in a 120/70. The next part to note on our arterial waveform is everything under this big wave in the blue area represents mean arterial pressure. So the average of all of this altogether will be the mean. And remember, we divide it into 1 systole, 2 diastoles, divide by 3, gives us our mean arterial pressure. The upslope, the systolic upstroke, also represents contractility. And once the dichotic notch happens and our aortic valve closes, that downstroke actually represents our systemic vascular resistance, or our afterload. Please note the arterial waveform is slightly behind the ECG. The mechanical action is slightly behind the electricity, and our systoles that are represented by that peak systolic in the arterial waveform versus our QRS, it's behind about 180 milliseconds. Also worth just showing you is a point at which the aortic valve opens is at the beginning of that systolic upstroke. So of course, when the ventricle starts to contract, that is when the aortic valve opens, and then where it closes is after that systolic decline. The dichotic notch happens, representing the aortic valve closure, and then we have diastole. And you can see the cardiac cycle separated there with the green and the orange into systole and diastole, and the aortic valve closing is what separates it. In the next wave, the aortic valve will open at the bottom of that diastole, and then the next systole will happen. Another factor when assessing the arterial waveform is, of course, pulse pressure, and that's the difference between our peak systolic pressure and our end diastolic. So the difference between the 120/70 will be a pulse pressure of 50 millimeters of mercury. And that increasing or decreasing also goes with many conditions. A very important factor when assessing your arterial waveform is something called damping. Not dampening, it is damping. And this influences the energy of the pressure wave. If your arterial line is over damping or over damped, it will have less energy in it. If it is under damped, it has too much energy in it. And that energy affects how the arterial line tracing occurs on the monitor. If it is overdamped, you're going to have a falsely decreased systolic and a falsely increased diastolic. And on the opposite side, on underdamped with the increased energy, you will have a falsely increased systolic and decreased diastolic than what is actually accurate. What's important to note in all of these cases, the mean arterial pressure is reliable, but you'll have these inaccurate systolics and diastolics. And a good way to think of this is, unfortunately, this 80s hairdo. So if it's overdamped, if there's too much moisture in your hair, it lies flat and it has no energy. If it's underdamped or dry, you're going to have this big bushy frizzy afro. It's just an analogy to remember the term. So remember, overdamped, so wet, too much water, is going to have dry, limp hair, less energy, and you're going to have a falsely low systolic and high diastolic. If it's dry and frizzy, underdamped, you're going to have increased energy, and you're going to have a high systolic and low diastolic. So how do we assess this damping phenomenon? So we need to do a square wave test. So we activate the flush, wait 1 second, and release. So in an optimally damping state, or a normal arterial waveform that doesn't have over or under damped influence, in a square wave test where we activate our flush, we should see a nice square, and then once you let go, while it's balancing itself out, we will see 1 or 2 small oscillations, and then the arterial waveform that we know well. Then we know it is optimal, and we can trust the systolic and diastolic. In the underdamped scenario, when you do the square wave test, you're going to have multiple oscillations, much more than the 2, and you'll see a little fibrillatory line almost, and then the arterial line taking off as normal. It's a high energy state, and you're going to have an underdamped line with the falsely high systolic, low diastolic. On the opposite side, the overdamped, the square will probably already be impacted. It's going to be slow to make that square, not having perfect right angles, and it will have no or less than 1 oscillation before the arterial line tracing that you know. Okay, so now that you understand the difference between overdamped and underdamped, once you've identified that based on the oscillations and of course that slow upstroke of the square wave, it's time to troubleshoot. This needs to be corrected so that we can get back to normal and have more reliable, accurate readings. So let's have a look first at overdamped. Okay, so like I said, it's got the slow square wave and no oscillations coming back to baseline. We're going to have a smaller SPP and a higher diastolic blood pressure. Once you've seen that, try to check that all the taps are closed properly. Check your pressure bag. If it's too little pressure or if the bags run dry, it can also be a cause. And I think that's probably the most common that I've seen in my experience in ICU. If there's a kink in the tubing, if there's a large air bubble, and of course if there's a thrombosis on the tip of the arterial catheter. So maybe an aspiration and a flush you could also do. If you have the opposite issue and you've identified underdamping, you will then have a normal square wave, but with more than 2 oscillations to get to the baseline, which I've indicated there to show you an example. This is going to give you a hyperenergetic waveform, and you're going to have a too high SPP and a too low diastolic blood pressure. So to get that back to normal, we will have to check if the patient's hypothermic. Tachyarrhythmias can do this. Smaller air bubbles also increase the energy of the electrical impulse. And check also that our pressurized tubing is non-compliant, large bore, and short. If we add too many extensions onto the tubing, this can also occur. Another factor to consider when you're nursing someone with an arterial line or monitoring someone is the term swinging. You'll often hear a shift leader or a doctor walk past you and say, "Oh, you've got a terrible swing on your A line." You're like, "What?" This is what they're talking about. And I hope you can see it on this picture below. It's almost as if the A line is going lower and then higher, creating this wavy type of effect instead of staying on a baseline. And often this can also occur with respiration. So how we identify it more accurately is if you have a systolic pressure variation of more than 10 millimeters of mercury. So if you look at the lowest one and the highest one, if there's a difference of 10 millimeters of mercury, we can say that is significant. And it's the equivalent of SVV on the cardiac output monitor, stroke volume variation, but obviously we're not measuring stroke volume per se in the A line. We are measuring systolic pressure, but it's a similar principle. And if we see that, we also can consider perhaps that the patient is behind on fluid. Remember always, and I'm probably going to repeat this many times in this talk, never to give fluid based on one variable or one observation that you make. Giving fluid is going to require many variables to be telling you the same thing and to have an agreement and a bigger picture within the patient to actually make that clinical decision. But if you see a swing on an A-line, it could be indicating your patient is behind. Other things that it could be is excessive right heart overload, severe asthma, pneumothorax, massive pulmonary embolism. All things that decrease the right ventricular compliance. Tamponade, right ventricular failure due to infarction could also be one, but most commonly it's hypovolemia and severe vasodilation. Let's talk about our dichotic notch. So we've already discussed the arterial waveform and I've shown you where the dichotic notch sits. But assessment of where in that diastolic downslope you're finding your dichotic notch can also lead to some clinical decisions. Remember, once again, to make a combined observation and a big picture before you actually do anything. But these are quite interesting, especially if you don't have a cardiac output monitor on. So if you are simply assessing the arterial waveform and you see your dichotic notch, it should be, and remember, it's all about where the aortic valve closes. Look at the third figure there. It should be about a third of the way down if you take the entire diastole downslope. So a third of the way down, our aortic valve should close. And why do I say a third? Remember that aortic valve closing separates the cardiac cycle between systole and diastole. And we know when working out a mean arterial pressure that one systole plus 2 diastoles gives you, and divide by 3 equals your mean. So typically your systole should be 1/3 of the cycle and diastole 2/3. And what separates it? The dichotic notch, where the aortic valve closes. So we're looking for it somewhere in the first third or at the first third of that diastole downslope. All right, so if we see it beyond that, in other words, almost late, the patient might be vasodilated. The dichotic notch is lower, and it might indicate to you that your patient needs more pressors. The opposite of that, of course, vasoconstriction, is a dichotic notch much higher up. Remember, if your patient's very vasoconstricted, you're going to need a higher pressure to open up that valve, and therefore it's higher up on this curve. Remember, once again, if you make these observations, check it out further and see if you can see more signs of vasoconstriction or vasodilation. You might wean your pressors based on that, but what I would do if I saw that and observed it, I would do a full assessment, but then perhaps add the cardiac output monitor to make sure of that diagnosis that there might be a problem with your SVRI. Let's talk about how we do this square wave test, and this might be new to many of you. So we know how to flush an arterial line, and it's basically that. It's a quick, short flush. So we just find different arterial lines do it in a different way, but that little squeezy thing at the transducer, for lack of better words, and we just do a very short flush for about 1 second. At the same time, we observe our arterial waveform trace, and what we're expecting to see is a quick upstroke and a quick downstroke, making that square shape. If it's slow and causing an acute angle, that could be indicating an overdamped line. But perhaps more importantly is observing the oscillations that follow straight after that. So once you release the flush, and we're getting back to now seeing the arterial trace, it makes a few oscillations trying to find the baseline. And in a normal situation where we've got the right amount of damping, we would then have 1 to 2 oscillations, and that would be normal. And then we know that our systolic and diastolic trace and values are correct and accurate. If we have no oscillations or less than 1, in that example, which you can see there, we would probably suspect that the line is overdamped, and then we follow the troubleshooting for that. There will often be the absence of a dichotic notch as well. In the opposite problem, the underdamped, we will have too many oscillations, so more than 2. And that will give us a high energy tracing, and we're going to have inaccurately high systolics and inaccurately low diastolics. Bear in mind, in all 3 situations, whether your arterial line is normal or if you're overdamped or underdamped, your mean arterial pressure is reliable if you've zeroed it to air. But even with these issues, the mean is reliable. It's just the systolic and diastolic which are affected by the damping and should be corrected according to the troubleshooting. A best practice reminder for all these checks of the arterial line is always to zero to atmospheric air at least 12 hourly. You can repeat this when you change the patient's position, for example, if they get into a chair or so on. But 12 hourly should be adequate, just that you know for sure it's been done at least once per shift. Other maintenance checks are about 4 hourly should do, and that includes a proper level. So there's different methods to do this. I've seen some interesting ones here. But as long as you have your transducer at the phlebostatic point, and where is that again? 4th intercostal space, mid-auxiliary. That is where our right atrium is, and that's where we're measuring. So remember to assess 4th intercostal space, mid-axillary, and to make sure your transducer is at the same level. Whether you use a Carpenter level or some other method, make sure you're using some sort of method and not just eyeballing it. Because for every 10 millimeters, so 1 centimeter that you off of this point, it equates to about 7.4 millimeters of mercury. So say a 3 centimeter difference in the level is going to equate to 20 millimeters of mercury being off. And that is quite a big discrepancy in blood pressure. So make sure the level is correct, especially when you change position, after x-rays, after bathing, all those kinds of activities. Okay, so besides leveling, we're going to do a square wave test for every 4 hours, as well as setting the optimum scale. Often if the scale is incorrect, it can look like overdampened. Okay, at the same time, check all the equipment, especially that pressure bag. We've learned now how important it is. Check that it's pumped up to 300 millimeters of mercury. Check that there's enough fluid. Do you need to make another bag, etc. Check the site of the arterial line for bleeding, swelling, hematoma. Do a dressing check at the same time. And then, of course, check the patient himself for the 5 Ps of the neurovascular assessment, which are pain, pulse, paresthesia, paralysis. Let's move on to central lines. So what are they exactly? They're large bore catheters close to the heart. They terminate in either the SVC, superior vena cava, or the IVC, inferior vena cava, depending on where they were inserted. And what are those insertion sites? So we can use either the internal jugular, the neck, subclavian vein, or in some instances even the femoral vein, and those are the ones that end in the IVC. Unfortunately, those values are not too reliable, and of course the waveform will be heavily impacted by not being close to the right atrium. We also don't prefer femoral access because of it's a dirty area and it's not good for CLABSI or sepsis. But sometimes in an emergency and when a patient is periphery shut down, that's the only option you have, and it must then be used. But once the patient is stabilized, they say within 24 hours, we should move it to a better site. So what are the indications for the central line? There are quite a few. Let's start with medication. So some of our medications irritate our peripheral veins, for example, potassium, and are better administered in the central line where they can dilute with a bigger volume of blood. Vasoactive drugs for the guaranteed delivery and consistent delivery of them are preferred in a central line. So you can start adrenaline on a peripheral line, for example, but if the patient bends their arm or the peripheral line tissues, which we don't have that risk of in central lines, you're then going to have no administration for that period, and of course the patient will get unstable. So anyone on vasoactive drugs should actually get a central line, and the nurse is very important to remind the doctor, be an advocate for your patient and remind them. Once you've started inotropes, you actually need a central line to be inserted. Fluid administration is definitely another reason to put in a central line. With the large bore, you can deliver it much faster. Parenteral nutrition, if your patient can't take oral nutrition, for example, you might need to give parenteral through a central line. Also hemodialysis, temporary pacing, also happens through a central line. Hemodynamic monitoring, which we're going to talk about in a minute. And of course, we've mentioned poor vascular access. If we look closer at our central lines, you'll see they're made up of many lumens that are within the actual tube. Have a look at that cross-section of the triple lumen and you'll see the 3 individual holes or lumens within the CVP line. And this ensures that we can give different agents or different medications that won't interact with each other. There's also some functions that are applicable from this feature. Let's quickly have a look. So in a typical CVP line, you might have different colors or for our different lumens, but have a look at the writing on each lumen and it will say distal, medial, proximal, depending how many lumens you've got. And in this example, our brown lumen there is the distal. And why am I pointing this out? It does make a difference to where you administer things, and the distal lumen in particular is where you would want to do your hemodynamic monitoring. This is where we're going to transduce the CVP. And why on the distal? Because the distal means the one that terminates or ends at the furthest away hole. So each of those lumens end in a different hole along the CVP line, and distal is the one right at the tip. And the tip of the CVP is right there by the right atrium in the superior vena cava, just before the right atrium, and will give you the most accurate readings. So that is the one that should be reserved for CVP monitoring. Most of the time, that is also the largest bore, which is also the gauge is indicated on the lumen. And that one is the one you'll use for active fluid resuscitation. So if that is the indication and you also want to measure the CVP, it can be done. You just put a 3-way tap, and then on the hour when you want to measure your CVP, or in between when you want to check out your CVP reading, just turn the tap so that it's exclusively on the transducer only, and you'll get an accurate CVP. And then you can turn it back to the fluid administration. So it can be shared, but don't monitor it on another lumen. Always use the distal. On the proximal side, the function that's reserved for proximal is blood sampling. So if you draw blood from the proximal, it's going to have the most original blood that's not mixed with TPN or inotropes or sedation or maintenance with glucose and potassium. It's the one that's furthest away from the heart, and because the blood is traveling in one direction into the heart, you shouldn't have a mix. That is the lumen we use for blood sampling, proximal. Our other lumens can be used for maintenance or inotropes, which we group together, or sedation group together, but ensure that you don't put any fluid boluses on these, because it will act as an inotrope or sedation flush, and you'll get a bolus in delivery of those agents. Let's have a look at some of the factors that increase our CVP value or decrease. So remember, we are now measuring at the distal end of the CVP. It's sitting in our superior vena cava close to the right atrium. So we're measuring the pressure on the right side of the heart. And most of the time, an increase or decrease is caused by too much fluid or too little. So one of the factors that increase would be fluid overload, cardiac tamponade. If we've got a restrictive cardiac function, we'll also have backflow and an increased pressure into the right atrium. Pericardial effusion, a similar mechanism. PEEP if your patient is mechanically ventilated and we have positive end expiratory pressure, which is continuous on our ventilator. If it's, say, 10 centimeters of water, it's the equivalent of around 3 millimeters of mercury on the CVP. I used to think 10 PEEP was the equivalent of 10 CVP, but in normal lungs, it's actually only about 3. If we have right heart dysfunction, we will also have an increased value in the CVP because we'll have a buildup of volume and pressure. And tricuspid valve issues, stenosis and regurgitation, will both give us an increase in CVP. In stenosis, it's going to be difficult for the right atrium to empty into the right ventricle, increasing the pressure. And in regurgitation, with the backflow of blood in the wrong direction, we'll also have an increase in volume and pressure. On the opposite side, on the decreasing side, we might have volume loss and therefore less volume, less pressure in our right atrium, dehydration as well, and of course veno or vasodilation. Very important to note though, is that as a clinician making decisions, we wouldn't make a decision on fluid based only on this single random value on its own. Way more important is the trend. So say in a normal person, a CVP should be around 0 to 6 millimeters of mercury. It's not an absolute. The trend monitoring will be more valuable. So say you're monitoring your CVP and now it is about 8, next hour 8, next hour 9, next hour 11, next hour 13. You can definitely see an upward trend, and that should make you put your detective hat on and have a look, is your patient getting overloaded for whatever reason? If it's just a fluid imbalance or is the right ventricle failing, you can do more investigations and a more holistic exam, taking more factors into account, and then you can have a look, is diuretic needed or so on. You need to see the patient as a whole, but the CVP monitoring is definitely valuable in setting you off in a direction. So let's have a look in more detail, the CVP waveform. Forgetting the numbers now, we did speak about the trend. We are looking at the actual waveform. And have a notice there that we have 3 positive waves through one cycle and 2 negative troughs. All these parts of the waveform are represented by letters, much the same as an ECG, but different letters, of course. Our first positive wave is called A. Our second positive wave is called C, which is a little bit less. And that third, more gradual positive wave is represented by the letter V. On the troughs or the downslopes, our first downslope is X, and it's divided into X and X1 by the C wave. On the more gradual side, we have that last trough represented by the letter Y. Okay, so now we have the letters. What do they represent? A is represented by atrial contraction. Remember, we are measuring at the tip of the CVP, sitting close to the right atrium. So as the pressure increases in this only specific area, it's going to give us more positive, and as the pressure decreases, it's going to go negative. So basically, we are measuring the cardiac cycle from the perspective of the right atrium. So our first big pressure is from atrial contraction. This is generated by electrical current by the SA node. On the ECG, we see a P wave. On our CVP waveform, we will see an A wave. As this continues and the blood goes from the atria to the ventricles, our tricuspid valve will close. And that little bit of pressure that goes back now to the atria when that valve closes will create this small little bulge there, a smaller positive represented by C. As the pressure goes down, as the blood leaves the atria into the ventricle, it's represented by that downslope of X. And remember, I said it's divided into 2 sections. Atrial relaxation, we have the C wave represented by the tricuspid valve closing, and then of course X1 is the downward movement of the tricuspid valve as the ventricles contract. The more passive of the waves is the V and Y, and it's a passive part of the cardiac cycle. V is the passive filling of the atria. So remember, in the cardiac cycle, once the tricuspid valve closes, the SVC and IVC during ventricular diastole start filling up the atria again, together with the coronary sinus, small amounts of blood. But as the blood comes back into the atria, we have a V wave on our CVP. The tricuspid valve then opens and we have a passive filling of the ventricles, and the atria will let go of that blood and fill up the ventricles, and of course the pressure in the atria will go down, represented by Y. So let's have a look in orange now what exactly is happening in the cardiac cycle again. So let's start over. We have atrial contraction represented by A. What is happening there in our cardiac cycle? It's the atrial kick. The atria contract and move 20% of the preload from the atria to the ventricle. On the ECG, we see the P wave. The C wave is the tricuspid valve closing. When it closes, a little bit of blood accumulates again in the atria, and we have this small little pressure wave in a positive deflection. The V wave, the last positive, is more gradual, and that is the passive filling of the atria from the SVC, the IVC, and the coronary sinus. Our troughs, the first one is X, where we have atrial relaxation, and it is divided by the tricuspid valve closing. We then have X1, where our ventricles start contracting, and because the pressure is becoming so low in the ventricles, it pulls the tricuspid valve a little bit towards itself, and the pressure goes down very steeply in the atria, and you get X1. Like I said before, the V is then the atria filling up again with blood, and as the tricuspid valve opens and the atria fill up the ventricles, we have the Y wave, where the blood leaves the atria and goes into the ventricles, and that is 80% of our preload passively filling. That is one part of this one cardiac cycle, and the next A wave would be the next thing to expect. We can see it there lined up with an ECG, and we can see the difference there between diastole, systole, and then diastole again. I know this might be a new concept for a lot of people, so I just want to go through a mnemonic about how to remember these waves and what they represent, just to make it a little bit easier. So I've put the letters in green that correspond. Okay, so A wave represents atrial contraction. The next little positive deflection, the C wave, represents tricuspid valve closure. So it's when the tricuspid valve snaps shut or closes. The X represents atrial relaxation or atrial diastole. The V wave is venous filling, that passive process of the blood returning via SVC, IVC, coronary sinus to the right atrium. And the Y is when the right atrium empties that blood into the right ventricle, the Y being empty. I hope this helps you to remember. So why do you need to know all these new letters and what they represent? So the CVP waveform can tell you a lot about your heart. Here are some of the abnormalities that you might pick up. So the first one is atrial fibrillation. So if you think about it now, so we're in the perspective of that distal part of the CVP, measuring the pressure in the right atrium. If we suddenly go into our atrial fibrillation, we know the atria are just shaking. They're not doing that nice, steady contraction for every QRS. The electricity's gone a little haywire, and it's not the SA node conducting that electricity nicely through the AV node. We've got some weird foci that are doing funny electricity, and we're getting a shaking atrium. We lose our atrial kick because the atria are no longer doing our nice contraction. So how does this look on the CVP waveform? Obviously, we're going to lose our A wave. We're just going to have these small fibrillatory waves, and then everything else should be the same. So we have our C wave, we have a V and a Y. Our X will also be a little bit more difficult to see because of the loss of that atrial contraction. So this is useful if your patient goes into AF. You should definitely do a 12-lead ECG. We should be able to tell from the ECG. But if it is a tricky one, you can look at the CVP waveform as well, and you'll see this example where those little arrows are showing the fibrillatory wave instead of the A. The next one that you'll be able to identify on a CVP waveform is AV dissociation. Remember, this is also called a third-degree block, and the characteristics of this is that it's usually quite slow, and there's no longer a relationship between the P and the QRS. The SA node and AV node are firing independently, and because of that, we sometimes get an overlap where the atria and ventricle might fire at the same time, and that causes a regurg into our jugular vein called a cannon wave, and it's represented there on the CVP waveform as that C and A happening at the same time because our tricuspid valve is open when the ventricle contracts, and you get this backflow, and obviously that backflow creates more pressure in the SVC, and you're going to have an amplified wave. Obviously, it's going to be irregular as well. Another one that can be seen on a CVP waveform is tricuspid insufficiency. So that is when our tricuspid valve doesn't close properly, and there's going to be access for backflow. So when our ventricle contracts, instead of the blood going forward to the lungs, some of it's going to go back into the right atrium. So of course that's going to increase the pressure in the right atrium, and the CVP is going to show a positive waveform. So how do we see that? So if our tricuspid valve doesn't close properly, we're going to lose our C wave. And also, instead of our X wave where we have nice atrial relaxation, where the blood goes forward into the ventricle and onwards, we now have blood coming back towards the CVP during this time in the cardiac cycle, and we're going to have a very large V wave instead, which you can see in this example. The opposite valve dysfunction is tricuspid valve stenosis. So in this case, our valve is stenosed or occluded, partially occluded. The hole is not as big as it used to be. It might be from calcification, and it's going to be more challenging for the right atrium to eject blood through into the ventricle. The afterload is going to be higher on that right atrium because there's more resistance now to overcome. And because of that, we're going to have excess pressure now in the right atrium, which is going to give us an amplified A wave. We'll also have a slower Y descent because the blood passively takes longer to go from atria to ventricle with the stenosed valve. The next abnormality is a group: pericardial constriction, right ventricular infarction, or a restrictive cardiomyopathy. And these have very distinct tall A waves as well as tall V waves. In other words, more pressure in the atrium due to all of those conditions. It's going to give you more pressure during atrial contraction as well as more pressure during atrial relaxation because it's not going to be able to flow into the ventricle as well as it should because of all these constrictive reasons. The last one is tamponade, and similar in having a tall A wave as well as a tall B wave because it's also constrictive, but something maybe different is that there'll be an absent or diminished Y descent because the ventricle cannot relax as it should. The last hemodynamic monitoring variable that we use on the monitor is pulse oximetry. And remember, this is all about measuring how saturated the hemoglobin is with oxygen. And that is a big important factor in cardiac output, because remember, cardiac output is ensuring oxygen delivery to your organs, tissue, cells, periphery. So pulse oximetry gives a quantitative value for hypoxia. It's a non-invasive device. Remember, an invasive saturation will come from our arterial blood gas sampling. Non-invasive is going to be this little peg or probe on our finger. It indirectly measures saturation. What is the normal value? And this is very highly debatable, but I would say in a healthy person without any cardiac or respiratory issue, above 96 should be expected. But perhaps in an ICU where these kinds of conditions are more prevalent and really you need to look at your patient's clinical picture and history. But I'd say we should aim for a SATs above 94. And why that number specifically? If you have a look at this table of the conversion of SATs to PaO2, if you look at 94%, it gives its equivalent of 73 millimeters of mercury PaO2. When we go below 94, we are below 70. And as you know, if you do an arterial blood gas and your O2 is at under 70, you probably will intervene. So our goal should be 94 or 70. If you have a look at the 90 SATs, which is sometimes advocated for, it's only the equivalent of 58. And I think if you saw that in your blood gas printout, you would probably act. So just bear that in mind. How does it work? So the probe sends 2 wavelengths of light through a part of our peripheral body, whether it's a finger, a nail, which is your nose, lip, or an ear. And on the other side, a sensor records how much light was let through. And oxygenated and deoxygenated blood absorb light at different wavelengths. And with this information, it then results in a waveform. And this waveform has a terrible name. We use the word pleth for short. The full name, which I'm probably going to mispronounce, is photoplethysmographic. Thank goodness we say pleth for short. If we have a good pleth, then the saturation is accurate. So if you're seeing a nice pulsatile wave, we can bet the saturation's accurate. But if the patient is fiddling or it's bad perfusion to the limb, the saturation won't be as accurate. There are big limitations on saturation monitoring, and here are some of the limitations. So nail polish, artificial nails will affect this monitoring of the waveforms of light. So that is why it's part of our pre-op care that those are removed before a patient has saturation monitoring in theatre, and the same goes for ICU. I'm sure we've all been in a situation where you have a patient with cold fingers and the saturation just won't work, and we're wrapping them up in a towel trying to warm them up. Cold temperatures definitely affects that pulsatile wave. Darker skin patients also have a SATs that is overestimated by as much as 2%. And that is very significant, 2%, when you're starting to play with the 90, 91, 92 saturation. If we're being overestimated, a darker skin patient could actually be in the 80s, and we really should intervene perhaps quicker in darker skin patients. IV meds that dye your blood, for example, methylene blue. Carboxyhemoglobin will also affect our saturation monitoring because it saturates our hemoglobin with something else besides O2. And of course, our pulsatility. And this is very important to mention in the JJ&J world, because we do have patients on VA ECMO, for example. We don't have LVADs, but the same principle applies. When we have a laminar flow of cardiac output, we don't have a nice systolic and diastolic. We only have a mean, and we lose our pulsatility, we lose our pulse pressure because the machine is doing the work. And then we have this abnormal arterial wave. We have also difficulty picking up our saturation. Let's have a look at some holistic examples, and this is the best way to assess patients in the real world, is taking a few or multiple sources of information and how they relate to each other, not just individual factors. So let's have a look at this first one. We can see the patient has a sinus tachycardia of 114. It looks pretty regular besides the 2 beats that are causing all the trouble. Can you see them over there? There's a compensatory pause after each one. And well done to those who recognized what that rhythm is. It's atrial extras. And how do I know that? Because we've got a narrow QRS, so it's not ventricular. And we've got a compensatory pause. We've got a funny P wave, and in fact that P wave is sitting on top of the T, giving us an augmented looking wave there. These atrial extras are affecting our cardiac output. And why do I say that? If you have a look at the pleth or the SATS wave there, we've got gaps in between where those funny waves are. And as soon as sinus rhythm is restored, we have an increase again in our pulsatility and our peak of that saturation wave. Here's another one that's very important to look at all the information on the screen. So if at first glance this looks quite scary, is this Vfib, ventricular fibrillation? Are you going to act? Are you going to defib this patient? I do want to encourage everyone that's working in an ICU, if you're not sure, to always ask for help. If we cannot miss a life-threatening rhythm, so call for help if you're not sure. Let someone more senior assess with you. Do not delay because you're not sure. But in this case, this is nothing to worry about. And why do I say that? Yes, we can see something that looks like a fibrillation there, but if you look at the next pressure waveform, which is the arterial one, we don't see a loss in that cardiac output. If it was a true Vfib, we would lose our cardiac output and the A line would go flat. We wouldn't have a nice systole and diastole. If we're having a regular systole and diastole, it actually should be sinus rhythm, which it's showing there. And this is confirmed by the pleth wave as well, which is still maintaining a good saturation and a good pulsatility, which would be impossible in Vfib. So what is happening here? This is some sort of interference on the ECG leads. It might be physiotherapy. It could be the patient fiddling with their leads looking for their cell phone. In this example, however, this is very serious. And let's see how come I know that. So we can see the runs of VTEC, or salvos if you're fancy, and then it restores back to sinus rhythm for a few beats and then goes back into VTEC. And why is this so dangerous? Have a look at the arterial line waveform. It definitely flattens down when the patient goes into VTEC. The pulsatility is lost, so we're not having adequate cardiac output, definitely not. Even in the sinus rhythm where it improves, the systolic is only reaching about 75 millimeters of mercury. So this patient is probably very symptomatic. That is also correlated on the pleth waveform or the saturation, and you can see it also dropping and flattening out during those periods of VTEC and then restoring a bit in the sinus rhythm. This is definitely an emergency that needs your attention right now. All right, and then I thought we'd just touch on some of the other things that we do monitor on the bedside monitor, although they're not strictly hemodynamic, but we definitely monitor ECG. And we've gone into a lot more detail with ECGs in a previous month's video, so please have a look at that if you haven't already. But what I did want to mention today for very practical monitoring purposes is the question, how many leads do you need for safe cardiac monitoring? Because we often see patients being monitored with 3 leads, but it is not adequate. We need 5 leads for cardiac patients. And why do I say this? This is a deal breaker, this is a standard, this is a must. In the 3-lead configuration, all we get is Einthoven's triangle. And the only leads or views that we'll be able to see are lead 1, 2, 3, AVR, AVL, and AVF. And as you know, the only areas of the heart that we can monitor with those are inferior and high lateral. You cannot see the anterior side of your heart in that configuration. For anterior, we definitely need V1 to V6, one of them. And how do we get that? With the V lead, the chest lead, the white one. So say your patient had an anterior infarct or is coming back from a cabbage and they worked on the LAD. You definitely need 5 leads. You'll place that V lead from V1 to 6 wherever the problem might be. Remember, V1 to 4 is anterior, 5 and 6 are low lateral. So you'll place it wherever the issues are. Check the acute ECG. But if you don't have it, place it somewhere on the anterior side, and then of course on the monitor itself, choose 2 rhythm strips, one for the right and one for the left. And that way you'll have ST elevation or ST monitoring for right and left side of the heart instead of just the right side, as is the case with the 3 lead. Please make sure this happens so that you are safe. Your patient might have a big problem on the anterior and you're not even going to know, especially if your patient is ventilated and can't tell you they're having chest pain. It's a must. Cardiac patients must have 5 lead monitoring. The last factor we're going to talk about today is temperature, and the observation or monitoring and management of temperature is really something that it belongs to the ICU sister or the sister in the ward. We really need to take more care of our patients' temperatures. As we know, if you're hypo or hyperthermic, it affects your cardiac output. You can become vasodilated, vasoconstricted. It increases your risk of bleeding. It's a big problem and it needs more attention. So please pay attention to this. And how are we going to do it? Well, there's 2 types of measuring temperature, or 2 ways. Body temperature is measured axilla, forehead, or skin, but our critically ill patients, especially patients on inotropes or with poor cardiac output, ECMO in particular, with some of their volume extracorporeal outside of the body, all of these patients need core temperature management and core temperature monitoring. And how do we do that? Either through esophagus, nasopharyngeal, or TUR through the bladder on the catheter. We just add a connection, but you need the right type of catheter to be inserted, which nursing can do. And this will give you a proper core temperature that can be managed. This is very important. It really should be for all critically ill patients. And I've included a picture of that elusive blue cable that's always missing. This is the one that you need for this, and it needs to be looked after and available at all times. Maybe the most important part about hemodynamic monitoring is setting the alarms. And I've had the privilege of being in touch with a mentor or ICU guru who once said that the monitor should be seen as the little robot or the slave for the ICU nurse, and we need to program it to work for us throughout the whole day. It's your little helper. And the idea of it is not to program alarm settings that are just the normals of each factor. You need to program it according to your patient. You need to tailor it according to your patient's condition. And this is actually the art of nursing, is applying all this knowledge and tailoring the care according to what you see. So say, for example, the patient's heart rate is 72 beats per minute, which is in the normal range, and you set your alarms to 60 to 100. It's only going to call you once the patient is bradycardic or tachycardic. And this is crisis management, and that is not what ICU is about. ICU is predicting and preventing before you get to that part. So it's recommended that we set our alarms 10% above and 10% below what the patient is having. Have a look at your patient's last 12 hours and see where they're at, and set it so that it calls you appropriately. It doesn't have to be the normals. It can be narrower, especially if you're going for lunch or you have another patient. Set the alarms even narrower so that it works for you and calls you in time. Remember, you can adjust your alarms throughout the day. You don't have to commit to your initial findings, and the patient's condition might also change. Let's take this example of the 72 beats per minute, and you've set your alarms at a 60 to 100, which I don't recommend. And say your patient goes into atrial fibrillation of 121. So now your monitor's alarming. you need to change the alarms. You're going to have alarm fatigue, and you're going to tire out your colleagues and everyone around you and the patient himself. So we adjust these alarms again to say 100 to 130, for example. So it will call you if this AF is getting worse, but you've intervened. Say you started Cortisone X. You want the monitor to call you as well if that medication has worked, so that you can note when the patient medically cardioverted back into sinus rhythm. Don't leave it at 60 on the bottom because we say that's a normal heart rate. Set it on 100 so that when the patient comes out of the AF, it also alerts you. You need to make it work for you. Remember also, the QRS volume needs to be on, even if it's on a lower volume, but we need a QRS all the time in the background. A lot of the procedures and things we do affect our pulse rate. We can have vasovagals, but we also need that sort of constant conscious reminder of that our patient's heart is beating. You can quickly pick it up if you go have that, say, run or VTEC with the QRS that is on. Thank you very much for your attention and time and listening to hemodynamic monitoring. I hope this has opened our eyes a little bit. We often get shoved into the ICU with very little basic information, and we should all actually know a lot more about what happens in the ICU. Mainly why the patient has actually arrived there is for extra intensive monitoring. So thank you very much. Please look out for our TikTok videos, and we'll be doing ward rounds soon. Very practical session where we'll go to the actual bedside monitors and see what we can find. See you again next time. Bye.